So thank you very much for having me here to talk today about health inequalities. In doing so, I'm obviously quite conscious that I am a white male from a high-income country, from actually quite a high-income part of the UK as well. I'm university educated and I'm middle class, so in many cases, a lot of the topics I'm talking about don't really apply to me. And I think that's really important to think about in terms of the different health inequalities that we're going to be looking at here today. So starting off, what do we mean by health inequalities? And I think in some cases we have different misconceptions or different points of view as to what we might expect that to represent. So I've got two different definitions I'm going to look at here. The first one is from the NHS in the UK. Which looks at a couple of different things. The first one is things that are unfair and unavoidable. The second one is differences in health across the population. And the third is differences between different groups within society. And we'll touch on this more as we go through. You might also have heard the term health inequity. So the World Health Organization really, their definition of health inequity is quite similar to the NHS's definition of health inequalities. And they really talk about health inequalities as measuring those differences and how that can help them to achieve health equity. The terms are used quite interchangeably. It doesn't really matter necessarily which one's the right or wrong term, but just so we know what we're talking about here today. The next thing is really inequalities between who. So we heard about it in terms of different groups and between different populations. And these inequalities can be a variety of factors. I'm going to deep dive into some of the ones that apply most to AML and to cancer. But these factors can be all kinds of different categories. And this is from a brilliant report by the King's Fund in the UK, which is a think tank. And they've done a lot of work into health inequalities. And some of the different categories they pulled out. So the first were socioeconomic factors, and particularly income, which we'll look at later. Geography, whether that's between different countries or different parts of countries as well. In the UK, we have some specific protected characteristics that are protected from a qualities perspective. So gender, ethnicity, those are really important and less relevant in terms of cancer, but it's still worth thinking about is particular groups that might be socially excluded and therefore access health services in a different way. So before we get into sort of the detail of some of the inequalities, I think it's really important to think about the importance of perspective in this context, and particularly really in that definition of different groups of people, avoiding the concept of groupthink and assuming that all patients are going to be the same. And just a bit of a sort of comic slide to explain perspective and sort of really check ourselves when we're thinking about some of this. On the left-hand side, you can see a third party's perspective. So it's what you think you see when looking at a topic. And on the right-hand side, you see it from actually the end user's perspective. This baby toy might be brilliantly designed from your perspective, but someone else who sees it from a different angle ends up just looking at the bottoms of lots of different animals. And in terms of users of healthcare systems or patients specifically with AML, different groups of patients might experience things from different angles or different perspectives. And it's really important to avoid assuming all perspectives are the same and really thinking about what differences might come between those different groups. In case you didn't like the baby toy, I've pulled out a song. I think that's perhaps a different way of thinking about it. And there's a lyric from what's actually one of my favorite songs, Father and Son, which I always think of when I think about health inequalities, which is, if they were right, I'd agree, but it's them, they know, not me. I'm relieved I didn't sing those lyrics instead. But really thinking just because you think something applies to you does not necessarily mean it applies to either a different individual or a different group of people. So now getting sort of into the meat of some of these discussions. So at ALAN, which is the Global Acute Leukemia Advocates Network, a network of patient organisations, we were really interested in understanding what different factors might impact on the quality of life of acute leukemia patients, and really trying to understand if we could identify either particular groups or predictors for worse quality of life and where people might need greater support. Again, particular examples of inequalities amongst the community. So 3 of the things that we really pulled out, and I'll talk a little bit more about these in other slides, as well as other topics. But 3 of the biggest ones in terms of the best predictors were age, gender, and income, and not necessarily all in the way that you might think. So in terms of gender, what we pulled out was that female patients were more likely to report a reduced quality of life when undergoing AML treatment and just generally since diagnosis, compared obviously to, in this group, male patients. Particularly what we saw was a worse burden in terms of signs and symptoms, rather than just overall quality of life. And for example, we saw that females were more likely to report feelings of depression or anxiety, but I could have pulled out a whole host of different factors. For those who are involved in patient organisations or charities, I'm sure many of you experience the same as we do at Leukemia Care in the UK, where a disproportionate part of the audience of people you support are female, whether that's the patients themselves or the female carers or family of male patients. In terms of age, quite surprisingly, we actually pulled out that younger acute leukemia patients had a significantly negative quality of life compared to the broader cohort of patients. So again, some of the bits that came out in terms of specifics here were a larger proportion of patients not saying that not being able to carry out physical activities concerned them more than it did older patients. And they felt it was harder for them to continue and interact with the world compared to how they did before their acute leukemia diagnosis. In terms of thinking about some of these factors more broadly, age was actually something we did a separate project on in the UK, and we were really looking at it in terms of over 65s and some of the inequalities they may experience. So I think the first thing to think about here is it's not just about saying one group might have a worse experience or an inequality compared to another. It might actually flip depending on the factors, but overall certain groups clearly have a worse experience of care. So in terms of some of the things we pulled out here, and this was very UK specific, was that for AML patients, as you got older and it increased as age increased, you were much more likely to die from AML than from a younger patient, which was not particularly newsworthy to anybody. You were less likely to be able to join a clinical trial. You were less likely to be told about your prognosis. You were less likely to be given guidance on using the internet. Particularly once you got over the age of 85, there was not a single patient in our survey that had been given guidance on using the internet once they got to over 85. In terms of thinking about some of the other factors as well, so income and deprivation is a really common factor, and I pulled out a report here from Cancer Research in the UK because there was this brilliant quote which I thought summarised everything, and apologies for the length of some of it. But many of these things can be multifactorial, even for the same inequality, and that's why I wanted to pull this out. So for those with a lower income, they pulled out a higher prevalence of risk factors in terms of more likely to develop cancer, less aware then of the symptoms of that cancer once it was developed, and more barriers in terms of seeking help, less likely to then take part in screening, and then when they were diagnosed, they were more likely to be diagnosed via particular emergency routes, which were associated with a worse survival. Once diagnosed, they were reporting worse experiences of care, inequalities in terms of which treatment option people were able to have, and as a result of a lot of these factors, worse outcomes overall. Again, for many of us, I think we'll be aware of some of these topics, but it's really stark to see how this impacts at every single stage. And in terms of looking at the overall population, not just those diagnosed with cancer, the report from the King's Fund I mentioned earlier did some really excellent analysis at looking about the association between income deprivation in different, effectively, parts of the UK, and looking at how more deprived areas had a reduced life expectancy overall. And specifically for AML, socioeconomic deprivation, so in many cases lower income, is associated with a decreased survival for patients, which is hugely concerning. And a lot of specific strategies were recommended by the authors of that paper. So another one's thinking about ethnicity, and I'm thinking here particularly within the context of a specific country, because it can be quite different globally, and we'll touch on that in a minute. So this was a piece of work done by the Blood Cancer Alliance in the UK with a team of researchers from the University of Hertfordshire. And this is all different types of blood cancer looking together. And in the UK, for those who don't know, it's a majority white population, between 80 to 90% of the population. And we were looking at the subgroup of BAME, which is Black and minority ethnic. So we were looking at how their experience of care as a minority within the UK health system, and identified that they reported a worse experience of care compared to patients from a white background across a variety of factors. So there's an analysis of the UK CPES survey, which is an experience-based survey to look at care for cancer within the UK. And they reported worse experiences in terms of their overall care, waiting times for diagnosis and treatment, understanding their health condition. They were less involved in their decision-making. A really classic example of this is bruising in the context of leukemia, but it was harder to pick up bruises against a black skin than it was, for example, against a white skin, because healthcare systems were not necessarily designed with their care in mind. Thinking now about between countries and how some of the geography there might influence things. So very top line, because this is a topic in and of itself for a whole other meeting. Cancer survival, as I'm sure many of you know, varies massively between different countries around the world in terms of a whole range of factors. And then leukemia incidence is particularly changing and growing depending on what part of the world you come from. This gives rise to a whole range of problems in terms of health inequity, and in cases of different strategies that are needed to look at addressing this. One such example, not globally, but within Europe, is a project called Eurocare. So this has been running, I think, since 1989, multiple different iterations, but really to look at the trends and differences between different countries to see if we can identify where some of the causes are of those differences. So with a UK specific lens, it was some of the key data that showed that UK cancer survival lags behind a lot of Europe, in many cases in terms of late diagnosis, late uptake of new and innovative treatments. So really thinking about all of those inequalities from all kinds of different lenses. In terms of thinking about geography and the role that plays within a country, there's a couple of examples here. So the first one on the right-hand side looks at variations in 1 year survival for a variety of different cancer types. And you can see leukemia about halfway down on the graph. So if you just look at the range between, so it looked at cancer alliances, which is different groups and networks of regions of the UK in terms of delivery of healthcare. And if you look at the worst end of that spectrum compared to the best end of that spectrum, there's a massive shift in terms of the 1 year survival you would expect. And a lot of that is related to the geography of where people are being diagnosed and then treated. It's actually really hard, even in somewhere like the UK, where we've got reams of data, to get access to some of this information. So the Blood Cancer Alliance in the UK, which again is a network of charities, we actually came together and created a blood cancer dashboard in collaboration with Janssen as a tool to help clinical leaders and commissioners at a local level to work out what topics they needed to look at and how they could look to address some of those inequalities within their cancer alliance, within their CCG, and look at what the particular problems were at a local level. To give a sort of example of some of this very specifically, and actually sort of some of the strategies that have worked on to try and address this, there's a project that Leukemia Care in the UK are doing specifically around CAR-T, and I think it really sort of exemplifies how a number of these factors can be linked. So for those who don't know, CAR-T, chimeric antigen receptor T-cell therapy, a very specific delivery mechanism. At the time, there was only 9 centres in the UK licensed to deliver CAR-T. And as part of the treatments, patients needed to stay within an hour of the hospital for up to a month. And because, I mean, the UK is a relatively small country compared to some other places, and Nime's quite a lot of treatment centres compared to some other countries. But patients were travelling up to 280 miles to access that treatment within the UK. And because they needed to stay within an hour of hospital for a month, patients were needing to have accommodation for that period. And those who were struggling financially with accessing this were actually in some cases limited in terms of whether they could actually access this treatment or not. I'm pleased to say that we were able to work with a hotel group to launch a effectively service and fund where we provided free accommodation to patients who did need to travel to access this treatment, as well as grant funding to go alongside it. But it just gives an example of sort of how health inequalities, even if they're not obvious on the outset, something like distance to receive treatment can create an inequality in and of itself. So the last point I just wanted to make in terms of wrapping up some of these inequalities was to highlight that these health inequalities and the wider determinants of health are often interlinked. So geography and income deprivation, for example. Age is also quite often associated with geographic areas as well. So it makes it really hard to unpick and identify what some of these inequalities are and which one's actually driving the health inequality. But it also means the strategies to address them can be really complicated as well. So hopefully I've done a little bit of an introduction into what's a very complicated and very broad topic. And I will stop screen sharing now so we can jump into some questions and discussion. Thank you for listening. Okay, has anybody got any questions or comments they want to raise? If I sparked any thoughts in terms of health inequalities, jump in with your hands raised if you've got something you want to say.
I apologize for being a little late. All of that stuff is part of my 9-year experience. The one thing I least like to see on any charter is these survival rate charts. We have people going to the New York hospital that are very wealthy that can fly in for their monthly treatments. It's incredible about the inequalities you talked about. I've been part of that. I live close to a place. I can maintain the travel distances. I think you hit all the nails on the head. I don't know about racial inequality, but certainly there. The idea of older people and younger people. I have a friend whose 16-year-old grandson is in dire straits after a year. And, here I am. So it's a lot of different things that you pointed out, Zach.
Yeah, thank you, Ralph. I think, like you say, it's really hard. In some cases, some of these inequalities don't apply to us. In some cases, those inequalities do apply to us. And certainly in terms of trying to map and understand which inequalities to focus on and which to sort of, as patient organizations, we should be producing services or driving strategies, it's really hard, like I said, to get that data and to really understand how much they're impacting on people's individual lives, but also on the broader communities of patients we support as well. So yeah, thank you for the comment, Ralph. Eric, I can see your hand raised.
Yeah, hello, Zach. Thank you very much for this very nice presentation and overview. I have two questions. You didn't have only patients from the UK, huh? Or did you have only patients from the UK?
So in the Alan project, which I talked about, we had patients from all around the world. In some of the UK, some of the stuff Leukemia Care was doing, we were doing specific research in the UK.
And which kinds of difference did you see, or did you saw any differences between the several parts in Europe, the several regions in Europe? Like sometimes you see differences in from the north and the east of Europe.
Yes, a very broad question. I think the first thing to say in terms of the Alan project we did on quality of life, so we actually saw not just within Europe, beyond Europe. One of the things that came out was that patients in Europe as a whole actually reported a lower impact on their quality of life from acute leukemia than patients from other parts of the world. So that was something that was quite interesting to look at. In terms of between specific countries within Europe, it really depends on the factor. So we saw variations in terms of, for example, access to health services, access to support that came around it, access to information, a kind of topic in and of itself. And it's certainly something, so I didn't talk about it here, but we're doing another project as Alan, which is looking at patient experience. So looking at how their interactions were with the health system, what support they received, and what impact that has on their experience of acute leukemia. And there's a whole variation between different health systems in terms of whether you would drive some of them as inequalities. I think in a European context, we'd probably be talking about inequalities in Eastern Europe compared to Western Europe a lot of the time, but also inequalities within individual health systems. So yeah, lots of interesting stuff to look into there.
And did you see any links? I think we discussed it at our last meeting, that in several countries, for example, in the eastern part of Europe, patients don't have access or not enough access to drugs, to medications. So sometimes they don't have it, it's not available, or they can't pay for it. Did you see there something in your surveys?
So it's not something that we've done specifically in acute leukemia yet. I think it's actually something we were talking about in a different Know AML meeting, I think, in terms of mapping inequalities of access. An example of a group that have done this really well is Myeloma Patients Europe, where they've done an access atlas looking at every treatment, every indication, and sort of combination of treatments in some cases for myeloma, and looking at the availability of each of those in different countries within Europe, because it varies so much, and it's so sort of in many cases really complicated to keep track of because it's constantly changing. In some cases that's great because it means patients are getting access to it, but in terms of tracking those inequalities, it's really difficult to do. And I think something we are talking about, how we could do something similar, either more broadly than myeloma, but in acute leukemia specifically, or more broadly across hematology.
So by myself, I think it's an enormous important topic, because for sure it has an impact on quality of life of patients, not only on quality of care, but also quality of life of patients.
Yeah, absolutely. I mean, I think access to treatments, access to clinical trials as well, not just access to licensed treatments, a huge problem. And again, maybe something we could have a whole conversation about another day. I think that brings our questions time to a close. So thank you very much